Welcome to the AAN's webinar, Practice Perspectives for Aducanumab. All participant lines are muted, but you may communicate with us through the chat and Q&A features. Use the chat for technical problems. To submit questions for the panelists, use the Q&A feature. Panelists will be responding to questions submitted in advance, as well as some of the questions submitted live this evening. We may not have time to answer all of your questions on this 1-hour webinar. This webinar is being recorded and will be available tomorrow on AAN.com. I will now turn it over to our moderator, Dr. Kerver, and our panelists.
I would like to also welcome everybody here to the webinar. We hope to give you some information which will be helpful as you and your practices are trying to determine what you would like to do when it comes to aducanumab. I am Dr. Katie Kerver. I am a behavioral neurologist in private practice at Rocky Mountain Neurology. I am also a member of the AAN Coding and Payment Policy Subcommittee, as well as a member of the AAN Aducanumab Work Group. I have nothing to disclose when it comes to this presentation. Next slide, please. The other panel members who will be participating this evening include Dr. Sarah Benish, who is an associate professor in the Department of Neurology at the University of Minnesota and physician chief of neuroscience service line mHealth Fairview. She is a member of the AAN Board of Directors and Quality Committee, and she also has no disclosures. Mr. Dan Shook is a CEO of Allied Physicians, Inc. He is a member of the AAN Coding and Payment Policy Subcommittee, and he also has nothing to disclose. Our final panelist is Mr. Brian Sorensen. He is a senior administrator at the University of Maryland Department of Neurology. He is a member of the Membership Engagement Committee and Business Administrators Networking Group. He has consulted with NeuroNet Pro. Next slide, please. The American Academy of Neurology recognizes that there is controversy surrounding the approval of aducanumab, and we know across our broad US membership, there are neurologists who are opposed and neurologists who support providing this drug to patients. Even some neurologists who are hesitant about the efficacy of the drug may still be having conversations with patients about whether this treatment may be of value to them. Aducanumab is a complex drug to administer, and practices are looking for guidance. This webinar is intended to share perspectives of academic and private practice neurologists, as well as business administrators who have been making plans for workflows and practice considerations. The comments you hear tonight will be the opinions of these individuals. They do not represent any official American Academy of Neurology position. This webinar is not intended to imply that the American Academy of Neurology supports use of the drug or is opposed to its use. The AAN does accept external funding sources, and that does include Biogen. However, none of the funds which were received from Biogen were utilized for the funding of this webinar. Next slide, please. I am certain that everybody in the audience tonight is very familiar with aducanumab, but I just wanted to provide a very brief overview of the medication itself. So I believe everybody is aware that aducanumab is a monoclonal antibody which is directed against soluble and insoluble forms of beta amyloid. The results of the clinical trial for this medication were mixed. In preliminary trials, there was a decrease in the beta amyloid burden in individuals who received the medication, and this was also shown in phase 3 clinical trials. However, the 2 phase 3 clinical trials were stopped early because of futility, because they did not show a clinical benefit at that time. Reevaluation of the data did indicate that in a subset of the patients who were receiving the highest dose of the medication, that is 10 milligrams per kilogram, there was a decrease in the decline of cognitive issues as measured by one particular test the Clinical Dementia Rating Scale sum of boxes. There were also some proof that there was a decrease in the decline on two secondary endpoints on two other measures. However, this medication was not shown to actually reverse the course of the disease. Aducanumab was approved on June 7th, 2021, under an accelerated approval pathway for Alzheimer's disease. In July, the FDA updated the labeling to help narrow the indication for the patient population eligible for these infusions. At this time, Aducanumab is limited to use in patients with mild cognitive impairment due to Alzheimer's disease and mild Alzheimer's disease. Aducanumab is a monthly infusion, and because there are so many controversies surrounding this medication, and because there are so many questions that our membership has, the AAN has created a resource page for individuals to use as a reference point. If there are any questions about Aducanumab following this webinar or at any point in time, the AAN can be contacted at practice@aan.com. So now we are going to start the actual question and answer part of this webinar. We had received many questions beforehand, and we do thank everybody who submitted questions for discussion during this webinar. We received many questions regarding how an individual should identify a person who might be eligible for receiving Aducanumab. And I would like to ask Dr. Benish now to share some of her thoughts on this topic.
Thank you. So I'm sharing the thoughts of our organization, M Health Fairview. I'm a general neurologist, and just to set the scene a little bit, in a large health organization that spans across the Twin Cities, we have 2 behavioral neurologists who between them work 3 days a week in clinic. So we do not have subspecialty expertise who can manage the assessment of all potential candidate patients. And so we are working as a team with general neurology and also asking our geriatricians in our health system to help us find candidates and have those conversations. So we're providing education across the system for that. In that setting for eligibility, in our mind, it's people who have mild cognitive impairment or early dementia as defined on cognitive screening. We are going to require a full neuropsych battery, but in the initial office screening, we want to see an MMSE of greater than 24 or a MoCA of 21 or higher to be eligible. We will require the individuals to be able to tolerate MRI scans and not open-sided MRIs. They need to be able to tolerate closed-sided MRI scans because we know we're going to need that initially and throughout the course of the treatment. And then we're going to have some reasons for exclusion if they have evidence of lacunar infarcts or past hemorrhage on MRI scans. They would be precluded from the study. We would preclude them if they have an uncontrolled seizure disorder. We would preclude them if they're on anticoagulation. And we are planning on also precluding people who test positive for ApoE gene. We will have genetic counselors available to discuss that with them, but looking at the trial results, our organization feels that that's the safest way forward. Dr. Korver, anything else you'd like to add to that list?
No, I thought that you did an excellent job. And I agree. I am in private practice and I have 2 other partners, but I am the only individual in that practice who sees individuals with memory problems. So I'm coming at this from a slightly different perspective, but I do share Dr. Benish's opinions that the individuals who should receive this medicine should fit into that category of mild cognitive impairment or mild Alzheimer's disease, as she defined with an MMSE. The other test which I do like to include is the Clinical Dementia Rating Scale, which does look at cognitive data, but also involves measures of how an individual is performing at home, how they are able to perform out in public, and if they're able to continue to complete their self-care needs, just trying to include the functional side of Alzheimer's. In order to meet the criteria, an individual should have a clinical dementia rating scale of 0.5 or lower. There were also questions that came regarding the CSF testing, and even some broader questions asking about would just the clinical evaluation be enough to determine if a patient is a candidate to receive aducanumab? And I'm going to defer again to Dr. Benish so she can tell me what her plan, or us, what her plans are at the institution. And then we will see what comes next.
We will be requiring amyloid confirmation. The rumors we're hearing from our local payers is they will be requiring amyloid confirmation as well. And that would be either in the form of amyloid PET scan or CSF biomarkers. Now, again, rumor from one of our payers locally, UCare, they're saying that they are going to require the PET amyloid scan, and they're not going to accept CSF, but they haven't fully published that, so we'll have to see. And in the CSF markers that are being allowed, there's Athena Diagnostics or a Mayo test. So that Mayo elevated p-tau over AB42 ratio. You can tell, again, I'm not a behavioral neurologist as I read these, and ATI less than 1.0 if Athena will be marked. And there is some discussion that there may be a serum biomarker for amyloid coming in the future, and we would evaluate that when it would become available.
Excellent, thank you. Just to add a little bit to your answer there, when you are looking for presence of beta amyloid in the CSF, generally you want to look for amyloid beta 42, which is the abnormally folded protein, but you also should look for the beta amyloid 42 to 40 ratio. That increases the specificity of that diagnosis. There have also been good studies which have shown that if you include measures of phosphorylated tau to beta amyloid 42, and total tau to beta amyloid 42, this also helps to include the specificity of your diagnosis. When it comes to the payers, Dr. Benish already alluded to the fact we're not certain what precisely is happening. I believe that Biogen is starting a program to help pay for part of that, but I do not have the specifics on that. There were also some specific questions still discussing the CSF about the exact orders that need to be written for that. I can tell you from my perspective as a private practice neurologist who does not have access to an academic lab, that this is actually a relatively large challenge. The fluid itself needs to be handled very differently from the fluid you would collect from a routine lumbar puncture. The fluid itself needs to be collected in low binding polypropylene tubes. These are different from the tubes which are included in your usual lumbar puncture kit, but if they are not used, then the test actually will not be valid. Also, once the fluid is collected, it must be stored and shipped between 2 to 8 degrees Celsius because otherwise proteins might degrade, and then you would also not get an accurate measure on the amount of beta amyloid. Also, I have read that it would be advisable to fill the tubes to their maximal level to ensure you have enough of a sample to test. So these are some things which make this testing a little bit different from routine lumbar punctures all of us might be familiar with. And I know that I'm in discussion with a few labs to try to determine who would be the best laboratory to work with to ensure my fluid is collected correctly and shipped correctly so that my patients do not have to have a second lumbar puncture. And just one thing, I know that at least in my area, LabCorp and Mayo are the two labs which can process that fluid, and I'm in Colorado, and I do not know if that varies from different places of this state. And Dr. Benish, I know that since you are working at an institution, you have worked up a workflow, and I don't know if there were more specifics you wanted to add to what needs to be included in those orders for the lumbar puncture.
No, I think you got it covered very well. So I think you've covered our workflow. I don't know if anyone else has anything to add.
Okay. I said private practice and being in more of an institution can be a very big difference. So. And then one of the other, or there were several questions asked about this, and they're sort of being grouped together, which Dr. Benish already touched upon, is in an MRI scan, are there certain findings which would be a contraindication to an individual receiving aducanumab? And some of the biggest contraindications, which Dr. Benish has already mentioned, but I'm just going to emphasize, are the presence of microhemorrhages. Generally, more than 4 microhemorrhages would be a contraindication. The presence of superficial siderosis can also be a contraindication. Both of these would be contraindications due to amyloid-relating imaging abnormalities, which is one of the biggest side effects, which we will discuss in just a little bit. As Dr. Benish also touched on, which is very important, if an individual has a contraindication to receiving an MRI or a PET scan, they should not be eligible for this medication, because we might be able to do lumbar puncture to prove beta amyloid pathology, but you cannot do another study other than an MRI in order to look for some of the contraindications to receiving this medication. The last question, which I wanted to touch on in this section, is were there other contraindications, especially when it came to medications? And individuals who received this medicine in the clinical trials were taking, or the majority of them were already taking medications for cognitive protection, including the acetylcholinesterase inhibitors and memantine. However, individuals who were taking blood thinners other than aspirin were excluded from the trials because they felt this would place them at a higher risk for the ARIA, the amyloid imaging related abnormalities. So now I wanted to switch just a little bit, because I also wanted to include Mr. Shook and Mr. Sorensen in this conversation. There were many questions about workflow and how people planned on trying to incorporate this medication, which requires a lot of screening beforehand and monitoring afterwards, into their practice. So actually, I will start with Mr. Sorensen.
So, and we have, I think, a good balance here, because I'm in an academic center and Don is in a private practice. And so we have different ways of doing things. We see patients in a hospital outpatient facility, not a physician office facility. We already have a significant infusion program for IVIG and several other neuromuscular and MS drugs. So we would just really incorporate that into our existing infusion center and add this. Obviously, the additional requirements that we would have to follow for this, we would build into the workflow, but we have a whole stable of infrastructure and infusion nurses, administrative staff to support that.
Excellent, thank you. Now, actually, Mr. Shook, if you had any information you would also like to share with us at this time from your perspective in private practice?
Sure, thank you. We do have in our private practice our own infusion center where we infuse MS drugs, those type of things as well. And we're now training our IV drug nurses to administer this drug, because we want to make sure it's done, the most efficacious way. We have had 5 patients in a clinical study over the last 5 years that have done very well with this. And most recently, we've had one private patient come in and wanted to pay out of their own checkbook for this procedure, hoping that as it moves along, it'll eventually be approved by a third-party payer. So, but we're watching this very closely. As Mr. Sorensen said, there's the VA. They've decided they're not going to use the drug. There are several Blue Cross Blue Shield plans around the country that have decided they're not going to. They're calling it experimental. So it's going to require a lot of hands-on and watching this and carrying it all the way down the line to the payment level. So.
Excellent, thank you. And Dr. Benish, I know that you have already alluded to some of the practices that your institute will be instituting, but could you please expand on that and just tell us if there's other information you would like to share?
Yeah, so what our decision in our health system is, so we have multiple infusion centers across our health system, and we have decided that we are only going to launch at our main central infusion center, which is on the university campus. Main reason for that is that we have neurologists on site with their clinics just a floor above that infusion center. So if there were to be any problems with the infusion, it isn't falling to our oncology partners who are typically the presence in infusion centers. We wanted to be more hands-on. So we're making that, I know it seems like a restriction, but again, I don't think these numbers are actually going to turn out to be very large in our health system when you look at all the kind of criteria that need to be met before you get to meeting the criteria for infusion. So we wanted to make it the safest possible environment for our patients and also for our neurologists to learn from to move forward. There has been some discussion that if it turns out to be safe, it could potentially be a home infusion, which would be appealing to patients who perhaps have difficulty with transport due to cognitive deficits. So I think that that's something to keep an eye on moving forward as we learn from our experiences here. And the other thing I'm going to just say is we're not going to let primary care doctors order. We are asking them to help us with the figuring out the inclusion criteria, like who is eligible for this drug, but we are requiring that a neurologist who is employed by the university be the person who writes the order, because we will be the people managing the consequences of edema and hemorrhage if they occur or other untoward side effects, and we don't want our primary care colleagues to get in over their heads on that setting. So I do think that this is important that neurologists are in charge of managing this medication.
Excellent, thank you. But that's a beautiful segue into the next question for you, which I will then also send back to the business administrators, about referrals and how your practice is managing referrals from primary care. I promise after everybody speaks, I'll give you my perspective from private practice, but I want all of our panelists to help me out right now.
Sure. We've received, like I said, one referral from a private physician to our practice. A lot of the primary care docs, like other neurologists, are very cautious in terms of what they want to do with this drug and who they think is eligible for it. And I do agree with Dr. Benish that we take referrals from the primary care, and the neurologist manages the patient process because of the side effects and the things that go along with that. So.
Excellent. Mr. Sorensen, do you have anything to add to that?
I agree with Donna on that. Clearly, we get the referrals. We refer them to our Alzheimer dementia specialist who is processing that. And so far, she has spoken to a few patients which she feels would qualify and for the criteria for this drug. And they've been somewhat reluctant because of the side effects that have been identified, the bleeding in the brain, et cetera. So I think, some of maybe the media or others expected this huge push on all of our practices to get, every Alzheimer's patient enrolled. And clearly, that's not going to happen clinically. And it doesn't seem to even, at least in our practice, we're not getting nearly as many calls about this than we thought we would before it was released.
Yeah, I think there was a lot of hype that went with this. So we're not seeing it either.
Excellent. Now, Dr. Benish, you and I in our private communications had spoken about this, and you had mentioned a monthly conference, which I thought other people might be interested in, especially if they are at an institute which has more practitioners who might be interested in this. If you could please tell us a little bit about what your institute is doing.
So we're always looking to learn, right? We're part of an educational university. And so with our shortage of our subspecialty expertise, what we want to do is really kind of deploy that expertise in a way where we can all learn from them. So the general neurologists or geriatricians would do the workup to see who's eligible. If they think that the patient is then eligible, they would submit the name to a monthly conference that hopefully will start in September. And then that case would be reviewed with a neuroradiologist who can confirm that the MRI is consistent with a safe patient to move forward. and that the behavioral neurologist can at least kind of hear the case presented and sign off on it so we can learn. And then we're hoping to even bring cases back there after people have had the infusions for a while and how they're doing, if we have any complications, so we can all learn as a health system together how to best take care of these patients. So hopefully that will be a good experience for all.
Wonderful, thank you. Okay, let's move to our next group of questions, which addressed problems with the potential adverse effects from this medication and monitoring for those effects. And I know Dr. Benish hasn't had a chance to catch her breath, but I'm going to start with her again.
Yeah, so I feel like we're taking a belt and braces, suspenders approach to our monitoring, but we really want to make sure that we keep track of potential adverse effects, right? Like first rule of being a physician is first do no harm. So if people make it through criteria and then they start with the infusions, we will be planning on doing repeat brain MRIs after the 3rd month, the 7th month, and the 12th month. So essentially matching when the doses get increased. And during that same visit for the MRI, we would be repeating a CBC, an INR, and an APTT to make sure that we don't have any kind of signs that they're at higher risk of bleeding. Just in case, as I said, we're worst case scenario folks in our organization. We will be checking pregnancy tests if that is a pertinent question, and we will be requiring like IUDs or something consistent if a woman has mild cognitive impairment and still of childbearing age. And then we will be discontinuing if we find any signs of moderate to severe ARIA-E or H, or mild to moderate superficial siderosis on the MRIs. One of the other things that will be a reason for us to discontinue therapy is if for some reason someone becomes unable to have MRIs. So if they have a pacemaker placement in between their infusions, they will no longer receive their infusions because we cannot safely monitor them with their MRIs unless they have a compatible pacemaker present. If they get started on anticoagulation for any other reason, we would discontinue their infusions because they no longer meet our criteria for eligibility.
Wonderful, thank you. And one of the issues which has arisen when conversations with colleagues of mine is how do you make certain that you can actually have a patient screened for the presence of ARIA, these amyloid imaging related abnormalities? I'm certain everybody in the audience is familiar with this, but just to be on the safe side, there are 2 forms of ARIA. There's the hemorrhagic form and the edematous form. Vast majority of people with the edematous form actually are asymptomatic and recover without any intervention. Hemorrhagic form can be mild, moderate, or severe. So screening for ARIA is incredibly important. The labeling indication at this moment is to have a baseline MRI and then a repeat one at the 7th infusion and before the 7th infusion, excuse me, and before the 12th infusion. There are other opinions as to how many MRIs should be completed, and I think this is something which will probably be ironed out as we learn more about this medication. But to get to the practical question of how do you know that your neuroradiologist knows what to look for, I would have a discussion with them beforehand. I would ask them specifically if there's a group you usually use or several groups. I would ask them, are you familiar with the findings of this? Would you be comfortable diagnosing it in a patient? Would you be comfortable communicating those findings in a very time efficient way with the practitioner so that they can then inform the patient and then decisions can be made about continuing or discontinuing the medication. There are 2 sequences that I know off the top of my head that are utilized in order to try to look for evidence of bleeding, and that's SWI and GRE. I am not a neuroradiologist, so I am not going to pretend I know all of the sequences that are available, but definitely talking with your neuroradiologist or a neuroradiologist at an academic institute who would almost guaranteed have experience with this would be very beneficial before you start ordering studies, so a patient does not have to get a repeat MRI at some point in time in the future because their first one was not done correctly. I did receive another question that was asking about other side effects with aducanumab, because we hear all about ARIA. And actually in the trials, the only other two adverse effects that were mentioned were urticaria and angioedema, but the incidence of these were very low. So generally, the main side effect we have to monitor for and have to be aware of is ARIA. Okay, so also a series of questions came up asking not just about the MRI monitoring, but also about monitoring with cognitive testing. And I'm going to ask Dr. Benish to say what her institute is planning on doing.
We're going to match with clinical neurology visits for sure at the 6-month mark and the 12-month mark, and most likely after at the 3-month mark. As I'm sure everyone's aware, we have access issues in neurology departments, so we've got to kind of balance the needs of these patients with other patients who need to be seen, but that's our hope at the beginning. And so those will be in-office cognitive tests and discussion with the neurologist, and then we will be planning on doing once yearly neuropsychological batteries to monitor progression that way. We are not planning on repeating amyloid PET scans or anything as we move forward, and that's mainly because we do not believe that they're going to be reimbursed. And so it's this balancing act of putting patients through testing and also not creating a large bill that they would have to privately pay for tests that wouldn't be covered by insurance.
So yes, I was planning on taking a similar approach because when you are monitoring for the presence of ARIA, an MRI is helpful, but a clinical visit is even more helpful because a patient might have a complaint that they didn't think was important. They said, oh, I've always had headaches and I've had one that's a little bit worse, but I just assumed it was my usual headache. That might prompt you to order an MRI outside of the ones which are in the labeling indication. So actually speaking to a patient and their care provider are going to be incredibly important parts of monitoring when an individual is receiving this medication. The tests which were utilized in the clinical trial to evaluate for cognitive status included the clinical dementia rating scale, sum of boxes, the MMSE, and then there were some other tests which were designed specifically for individuals with Alzheimer's, looking at their ability to complete activities of daily living. With any screen, you don't want to complete it too frequently, just because patients start to get irritated. But also, so it depends on how frequently one is seeing them in the clinic. If you would do one of these screens every time, if you would, if you're hearing an indication from the patient or their caregiver that there has been a change, that might prompt you to do all of the screens during that visit. But it's very important to not just speak with them, but to also try to have some kind of more objective data measure of how they are doing. I agree completely with Dr. Benish that neuropsychological testing is very important. An individual could do very well on a screen, but in more detailed testing, you might see decline in other cognitive areas which are not picked up by those screens. And that might actually lead to further discussions about whether an individual would still be a candidate to receive the medication or not. And that actually, before I lead to that next question, a point that Dr. Benish had made with should an individual have repeat testing to look for a decrease in the beta amyloid burden. This was done in the clinical trials at weeks 26 and 78, but one of the endpoints of the study was to demonstrate that there was a decrease in the beta amyloid burden. I think we can accept that the medicine is capable of doing that, and doing a repeat study does not necessarily add to your clinical decision-making as to whether a person should continue to receive this medication or not. But going to the next question, which is a very interesting one, is when should we consider stopping aducanumab treatment in a patient who has cognitive problems? And I would be interested to hear Dr. Benish's thoughts on this first.
It's a good question. I'm not sure we've completely ironed that out, on the learning spectrum. I think we were too busy trying to figure out how to get patients started, to be truthful with you. But obviously, if there's contraindications, that's an easy one. But then the question becomes, if people are advancing in their clinical disease, there's no clear effectiveness of the infusions at that point in time. And so what's the point where we stop? And other than that, we would stop at some point, I don't think we've ironed out where those lines are. And again, I predict that that's something we'll be taking to our monthly conferences to decide.
Excellent. I agree. This is still a very open-ended question. Remember, aducanumab was authorized for individuals with mild cognitive impairment and mild Alzheimer's disease. So if an individual is advancing to a moderate state of the disease, it is unproven if continuation of treatment would be beneficial or not, or would that place them at a higher risk for having side effects, including ARIA-E and ARIA-H. One very practical consideration, this infusion is monthly. And not only does it involve an individual going to an infusion center, but also it involves them having other monitoring studies, including MRIs, including clinical visits. And at some point in time, a patient might decide this is too much. They're not seeing any benefit and they don't feel that it would be worthwhile. And with every step of this medication, it's incredibly important to keep the lines of communication open between the doctor, the patient, and the patient's care partner, because this is not a cure for the disease. This could potentially decrease the rate of decline, but that decline is still going to happen. So making certain that your patient and your care partner's voices are heard when it comes to whether they feel it's worthwhile to continue this medication or not, I personally feel is very important. So let's involve our business administrators again, because there were many questions about how different institutions decided to handle this medication. And I know that you have touched on this before, but some of the more specific questions is specifically, how do you plan on handling the drug? Is it on your formulary? Will your center personally be infusing? And what the patient demand has been. As I said, I know that you have touched on some of these points before, but maybe if we can emphasize, or if you wanted to expand on some of the answers you have already given. I'm just going the way that it's on my screen, so I'm starting with Mr. Shook.
Thank you. We obviously would like to use the drug to help as many people as we can. But again, we're being very cautious. We've got experience with 5 patients that have been in a clinical trial for the last 5 years and have done very well. Not all patients will do as well. We know that. And so we're working with some of our primary care partners. We've got one that, like I said early on, that came in private physician who his wife was came out with mild symptoms, and he's paying for it out of his pocket. He's waiting, hopefully, that at some point it'll be covered by third-party payers. But again, it's very slow. We're slow walking this because third-party payers and the number of folks. When you look at it, it's about a $57,000 a year promise. When you start this process, and not many people have that kind of resources, if you will, to cover that without some type of insurance program. And so, again, Michigan, Kansas City, North Carolina have said it's experimental and they're not going to cover it. Medicare, it's still, we're still waiting to hear what Medicare is going to do with this process because it is so costly. But I think Brian pointed out early that because of the number of patients this could be used for, it may not be the resource consumptor, if you will, that everybody expected early on.
Wonderful. Mr. Sorensen, if you could please give us your opinions.
Yeah, so Don has the jump on many of us because his group participated in the trial. And we are just really now requesting our hospital formulary to put the drug on. Our Alzheimer's specialist is working with the pharmacy on that. So we are even slower in getting that going. I guess later on, some of the questions will come up, and I do have some information about where we stand with the different insurance companies on reimbursement. But again, it's two separate processes. So, we're still going through the clinical approval process through the hospital. And, that will take a good couple more months.
Wonderful. And Dr. Benish, if you could please share your thoughts.
Yes, so we have commitment from our organization that they will infuse the medicine right now. But as with every treatment, they will also do financial analysis. And if it ends up being something that isn't getting reimbursed and they're losing money, we will have to have repeat conversations with them about that in the future. Our pharmacy colleagues have actually been wonderful partners during this and have been on top of this from the get-go. And really, I'm just so blessed for how many great partnerships we have in our health organization. So I would just say reach out to these pharmacists if you're lucky enough to be in the health system with those resources. I think they would be good. I think we've had, as people can see from the comments and questions, this drug is controversial. I don't think anyone on this panel disagrees with that. And so we've definitely had members of our health system kind of come forward and say, we think that you should outright reject using this medication. And the agreement of our organization has been that we want to respect the decision that physicians make with their patients and have open, honest conversations about what this drug is and what this drug isn't, and what the cost of it is and how much it takes for screening. As you can see, there's a lot of screening. And then if they still are saying that it's their priority and it's their decision to be made, we want to try and make that drug available to them and be there to support them. So we're really embracing our ethos of shared clinical decision-making, not physicians making decisions for patients, to kind of work through the access for this drug.
Excellent. Thank you for those thoughts. Just before we move on to cost, there were a few questions that Dr. Benish had also touched on the answer to this about infusion. And is this something that could be done in an office? Is home infusion an option? At this point in time, I don't think there's any specific answers. Probably when this drug was released, people thought of infusion centers. If an individual has a small infusion center associated with their office, then definitely it could be associated with that. I know that in some conversations that the AAN has had with private payers, the question of home infusion has been brought up, but also we do not know what the answer is for coverage at this point in time. But let's shift, because there were a lot of questions about cost. And Mr. Sorensen, I think that you have some specifics. I know that Mr. Shook had mentioned some insurances specifically, which have declined, which have decided that they did not want to cover that. So let me start with you, Mr. Sorensen, regarding coverage of the medication, and if you know anything about coverage of the additional testing needed.
So just to put this in the monetary terms, as Don had said, it's $57,000 for the drug, plus these other ancillary MRI and other ancillary costs to monitor. So if somebody's doing self-pay, it's not just that drug cost, it's also these other additional costs, which are not insignificant. At this point, I think most insurance companies are waiting for what CMS is going to do. So where do we stand with CMS coverage, since probably about 80% of patients who would be getting this drug would be covered with Medicare. Something called a national coverage decision was initiated by CMS. There was a discussion period, and the AAN did submit comments during the comment period, which are viewable on the Aducanumab resource page at the AAN. The CMS will take about 6 months to figure all this out, and then they will open it up for another 30-day comment period. So the thought is that they would finish this entire process by about April of 2022. I also had just read that this would also cover other amyloid monoclonal antibodies, reduction of amyloid reduction in other related drugs that are coming out, such as the Eli Lilly. So once this national coverage decision is made, it may not be disease just drug specific for the current drug, but also cover other similar drugs moving forward, which I think is very good news. Other payers, some Blue Cross Blue Shield, as Don had said, have already said they weren't covering at this point, but I think most are waiting because of all the controversy and waiting for CMS before they're going to make a call on this. The VA is not putting it on the formulary. They are only recommending prescribing this in very exceptional cases. So, there is a lot of thought that's being put into this, and the insurance companies are just not coming to the plate and saying we're covering this at this point. And it's going to be several months before we hear about that.
Thank you for that. Dr. Benish, could you also tell us about some of the conversations that your institute has had with some of the payers in your area?
Yeah, so interestingly enough, I mean, I think the insurance companies are trying to figure this out and looking to us for input, right? So we decided that we want to sit down and have conversations with them, because what we don't want them to do is not cover the amyloid testing part of it so we can confirm who is eligible for the test, or not pay for the MRI scans for the safety monitoring. So we really wanted to develop a protocol to kind of say, listen, if we're going to move forward with this, and let's learn together, this is what we think would be best practices, and we'd like to share that with you as you consider your policy. And they have all been really open to that and to hear what we have to say, so they're not working in the dark. And if you think about it, we have the expertise at the university and behavioral neurologists and your local practices. So I would recommend reaching out to the local payers and starting that discussion, because if they just come out with a policy on the drug, but they're not supporting everything else that's needed to make that drug infusion safe, as physicians, we're not going to be comfortable ordering that anyway, right? And so then you're going to have some very difficult conversations with your patients as well. And so I think that this is now a time to kind of have those conversations. I know the AAN's having those conversations nationally too.
Yes, I did want to add that the AAN has had conversations with several private payers. They're very, very interested in knowing some of the practical issues that will surround use of this medication. Who would be a candidate? What are the tests that need to be done to determine who is a candidate? What are the tests that are needed to monitor the patients once they receive the medication? And of course, when would you think about stopping this medication? But now actually, Mr. Shook, I wanted you to make a few comments. I think that you know about the CPT codes that might be used when an individual is prescribing this medication.
Absolutely. There's not one specific CPT code, as the treatment occurs over multiple encounters, and there are many elements to consider. You may report 99483 for the initial cognitive assessment and care plan development, and an E&M visit for the follow-up visits when you're monitoring the patient's status. There are unique CPT codes for the required imaging, which will be billed separately, as would the actual J code. That J code is actually J3590, unclassified biologic. And at this time, though, there are no payers that have published coverage policies for the drug, and we're unable to definitely say which codes will be covered. So, with regard to administration of the drug, you would use code 96413 and 96415. For anything longer than an hour. So that's what I know about the CPT codes.
Excellent. I appreciate you sharing. I just wanted to make a few comments, and then there are some questions we did want to try to get to from the audience that were just submitted. There was a question about would beta amyloid PET scanning be covered? And I just want to make everybody aware that the AAN did sign a joint letter with the Society of Nuclear Medicine and Molecular Imaging, as well as the American Geriatric Society, requesting that CNS cover beta amyloid PET scans. And if you would like to see this letter, there is a copy available on the Aducanumab resource page. But to get to some of the questions which have just come in, there was one which was asking about the ApoE. And it's basically the question is that they have seen that this medicine is most effective in patients who are ApoE positive and over the age of 70, and they wanted comments on that. I will start. Definitely in the clinical trials, it showed that individuals who were either had a heterozygote or homozygote for ApoE tended to have a better response to the medication, but they were also at a higher risk for side effects. If you, especially ARIA, if you look at the numbers, it was 40% of individuals who were ApoE positive were at a risk for ARIA, E, and H versus people who were not. So that, I believe, is going to be a conversation that needs to be had with the patient and their care partner. ApoE testing is not covered by insurance as a general rule. So, should this be included in your protocol? What is your thoughts? What do you feel comfortable with? What does the patient feel comfortable with? But I know that Dr. Benish had other thoughts on this, so I'm going to ask her to share those now.
We are going to require people to get screened for ApoE, despite it not being covered as part of this. And we are going to go to our local payers and discuss that we would like them to pay for it. Initially, we're saying if you come back positive, we are not going to infuse you. I think that this will be an ongoing conversation, but our main goal is to mitigate risk of ARIA, E, and H. And so we feel more comfortable with that as we learn from the first population of patients. And maybe we'll regret it as we move forward, but we're going safety first on this.
Excellent, thank you. There was also a question about MRI protocol to evaluate for ARIA. I did briefly touch on that with the disclaimer, I am not a neuroradiologist. I would speak to a neuroradiologist who has expertise in ARIA. I said the two imaging sequences I know off the top of my head that are good for looking for blood are the GRE and the SWI. There are many other sequences out there, so I would highly recommend speaking to somebody, a neuroradiologist, before you order the test to make certain that you have the results that you are looking for.
If I might just add to that, we did speak to a neuroradiologist. They said SWI is more sensitive to find this than GRE. So they were highly recommending that we include SWI in our MRI scan protocol. So that is what we've done. And then we have discussed with them that we have a specific template that we want them to use that discusses microhemorrhages, superficial siderosis, edema, et cetera. Like, they are going to fill that template out for us so we can use their expertise and to continue to monitor that. And they were really open to looking at that, looking at the protocols that the trials use to formulate that, which have been shared. And so I think it's just a good time to have a conversation with your neuroradiologist.
Excellent. Thank you so much for sharing that. There was another question about using PET scans to monitor for treatment response. And I'm assuming that the person is referring to FDG PET scans, since we did talk about the beta amyloid PET scans. However, I'll try to answer both, and Dr. Benish can jump in. So this medication has not been studied, or the response to this medication has not been studied using FDG PET scans. So I don't think that there is a role for that. When it comes to repeating beta amyloid PET scans, even though that was done in the clinical trials to look for the response, that is not something which is in the labeling that we must do. If as a practitioner and as a person prescribing the medication, you feel this is important for you to have this information so you can tell your patient what their response to the medicine is, I think that you should be able to do that. However, Dr. Benish did mention, and I agree completely, we're not certain if beta amyloid PETs will be covered by insurance, and that would just be one to screen at the beginning. I don't know if they'd be willing to actually cover a second one too. But Dr. Benish, any thoughts?
I agree with you. Yep. Nothing to add.
Excellent. There was a question about a safe way to start the medication. And there is a titration schedule that is on the label for aducanumab. It's also available in a few publications which have come out regarding aducanumab. And so I would refer you to those. And somebody asked if Biogen has published the full results of their studies in a peer-reviewed journal yet. Not that I am aware of. I know that they have said that this is something they are planning on doing. I know that I have. Okay. At this moment, I don't see any additional questions that I'm not covering. We still have 5 minutes, so if somebody wanted to try to get a last-minute question in, but actually I'd like to ask the panelists if they have any final thoughts on this medication administration, how this will affect your practice. I would welcome them at this time.
I'd like to just make a point that was stated earlier, I think by Dr. Benish, but carrying it one step further, is if you go out and reach out to your third-party carriers as a neurologist and explain to them as part of your knowledge and how you're going to actually use this drug, that it is only going to be a certain relatively small subset of the Alzheimer's patient population, which is almost 6 million, we know, across nationwide and much more in the world, that maybe they would be more likely to approve this drug because they may have thought it was half of all the Alzheimer's patients before. So I think your knowledge as a neurologist conveyed relating to this could help these third-party insurance companies possibly be more open to covering the cost of the drug.
I'm sorry, I'm going to interrupt other people for just a moment before their comments. There were just 2 other questions that came in I wanted to answer quickly. One was the use of TPA in acute stroke patients receiving this treatment. I can tell you that has not been investigated. However, I can tell you an individual who has had a stroke in a year prior to receiving this medication in the clinical trials, that was considered to be a contraindication. And one very important question I thought was, would anybody be using a written consent? And given the complexity of this medication and the controversy that surrounds it, I think that would be an excellent idea. I do not know if anybody has developed one specific for this at this point in time, but definitely something to consider. And so now, Mr. Shook, Dr. Benish, if you had any other comments.
I would disagree with Brian. This is something that we're going to keep our eye on. We're going to watch to see. We'll probably be involved in more clinical trials to see what the long-term side effects are, so we can really sit down with our patients and explain the efficacy of this drug and what it can do for them, both in the short and long term. But I think there's more data out there that we need to see to feel comfortable with it.
Thank you for those thoughts, Dr. Benish.
Nothing more to add. I thank you for the thoughtful questions from everyone. I will be taking to my legal department the conversation about a written consent. I think it's an excellent question and something that we should be mulling over. So I learn every time I talk to a group of neurologists. So thank you.
Well, thank all of you. Just one last question that came in, which was asking about the phase 4 trials, which are ongoing at this moment. I do not know many of the specifics of it. I'm just going to add, since we gave the disclaimer that this is all our opinion, I am just hoping that in those phase 4 trials, they actually include more people of diverse background. The clinical trials were performed in basically a pretty uniform population. We do not have data how this medication affects individuals of Black, Hispanic, Indigenous, the Indigenous people. There's a lot that we are missing, and I'm afraid that those people might miss out on an opportunity for a medicine that could potentially help, or it's something that somebody might give them that could potentially harm. So I hope that there is wider inclusion in those trials. That is my personal opinion on that, and you can take that as you would like. But I see we only have a minute left, so I would like to thank the panelists for their time and all of their expertise in this area. I would like to thank all of our listeners and thank you for your thoughtful questions. It is always wonderful to hear what people are thinking. And I do hope that this webinar was beneficial and that you did receive some new information that can help you in your decision as you're determining if your patients would benefit from aducanumab. And please do visit the aducanumab resource page. That is information there is getting updated all the time. And you can always reach out to the AAN with specific questions about aducanumab. And if we can answer them, I know we will be happy to try.